We're going to bring down the abstract philosophical theories to our concrete problem of who gets the organ for transplantation. Remember, last time we talked about at least 3 ethical theories: utilitarianism, which tries to maximize the good; Kantianism, which tries to give each individual an equal shot; and Rawlsianism, which tries to prioritize the worst off. Question is, how do they apply to the concrete situation of organ transplantation? So we're going to look at the values, principles, and various proposals for allocating solid organs for transplantation. Let's recap how it gets done today and changes that are being proposed to the rules regarding how to allocate organs. Remember, the United Network for Organ Sharing was a non-profit private organization set up by legislation under federal contract to make sure that allocation of organs was fair across the country. UNOS, as it's known, has a great weight in deciding who gets what organs in the United States. How does it allocate kidneys today? First, there's a screen for compatibility. You look at candidates. Do they have the same blood type so you don't get bad reactions? Do the tissues matches on what's called HLA matching? We need the same size. You can't put a big kidney into a small person. So we screen out people where there's a blood type incompatibility. Then, once you've got this pool of potential recipients, the remaining candidates are prioritized according to a set of rules based upon geographic location, payback kidneys owed to the OPO, and in particular, it's looked at 3 criteria for patients waiting for a kidney. First, waiting time. How long have they been on the waiting list waiting for a kidney? Second, how old are the donors so that you match an older donor with an older recipient? And third, what are the antibody levels? In 2011, there were 87,658 patients in the United States waiting for a kidney. There were 16,813 kidney transplants done from cadaveric organs. Almost 5,000 people died waiting for a kidney transplantation, even though there's dialysis available. Now, UNOS recognized that there are problems in terms of fairness and efficiency with their allocation system. First, not all people have the same ability to survive on the waiting list. Some people have more serious illnesses and might die while they're waiting, or have an increased risk of dying while they're waiting. Second, some people have more aggressive doctors or just know more and can get on the waiting list sooner. So if you use waiting list as a time, they're likely to get their kidney faster, even if they're equally sick with someone else or had their kidney disease diagnosed at the same time. And third, younger patients have a tendency to outlive a kidney from an older donor. So we have a mismatch where some younger people are getting older kidneys and older people are getting younger kidneys, and we're wasting years of functioning kidney. There have been policy alternatives being entertained by the UNOS committee to change how they allocate kidneys in the United States. One is to have age matching. That is, to give priority to more younger patients. That actually gains an extra 16,000 patient life years if you did better age matching. Second, allocate the top 20% of kidneys by prognosis. That is, give a kidney preferentially to people who have a higher chance of living a long time. This gives a priority again to younger patients. Gets you half as many years, 8,000 life years. And then change when you start the clock for waiting time from not when someone gets on the list, but from the first dialysis treatment, which would seem to give a more normalization. And that benefits people who don't know the system and can't navigate it as well. So here's a question for you. Which of these would you introduce to modify the allocation policy? Would you have age matching? Would you allocate the top 20% or 1/5 of all kidneys to people who have a better prognosis? favoring the young again? Or would you change when you start the clock on waiting time so that it corresponds to a more objective measure, beginning of dialysis treatment? Which one would you choose? Well, in its deliberations, UNOS decided not to include age matching because they felt that by giving priority to the youngest, it would be age discrimination. They did, on the other hand, allocate the top 20% to people who have better prognosis, thereby increasing the amount of the longevity of kidneys that are transplanted. And they also decided to allocate to start the waiting time clock based upon first dialysis, not simply when you get on the waiting time count. Is that policy ethical? And in particular, is it fair to remove to criticize age matching based upon the fact that it's age discrimination? So when we think about allocation of organs for transplantation, there are really 4 values that might come into play. The first one is we want to promote equality. This is a sort of Kantian value. Second, we want to help people who are worst off. That goes back to the Rawlsian argument that we've reviewed. Third, we want to maximize the benefits, maximize the number of people saved or the number of life years. That's a utilitarian or Millian argument. And then fourth, a lot of people have the intuition that there are particular people who are socially useful and they should get priority. So let's review these 4 values. Again, promote equality. Well, if you're going to promote equality in the case of a solid organ and it's of transplantation, it's equality of opportunity, not equality of resources. That means that people have an equal opportunity to get the kidney. You can't, after all, divide the kidney in half and give half a kidney to 2 people. So it can't be equality of resources. This, again, is an egalitarian argument, one favored by Kant. Second value is helping the worst off. That is, we think that people who are worst off in this world should get some extra benefit because of how hard their life has been. Now, there are different views of who might be the worst off, but this is a prioritarian argument. That's a complicated word. It also fits with John Rawls's view. He's the man who really strongly introduced this into consideration. Again, the third value is maximize benefits. This is a utilitarian argument consistent with Mill. And the idea is, which benefit do you want to maximize? It's hard to maximize saving the most lives, but we might save the most life years as the benefit. And again, the fourth value is promoting rewarding people who've been socially useful. And again, we have different arguments about who's socially useful. Would Steve Jobs be considered socially useful because he invented all this cool technology? Or is it more likely that we should give priority to people who are great scientists or great writers? So those are the 4 values that have so far been articulated. Can you think of other values besides equality, helping the worst off, maximizing benefits, and promoting social usefulness that we might consider in how we allocate organs?